How's it going, everybody? I know we're sort of in that mid-afternoon stretch, sort of a low point. You've heard from our international experts, Dr. Casper and Dr. Colombo, and now you get to hear from the guy they pulled in from down the street. But for those of you who aren't from Houston, welcome. It's really great to see a bunch of faces. I'm really happy that the meeting's in my hometown this year. It was a lot easier on travel. Got to see my kids last night. Thank you to DTRF for having us. I think this is a highlight of my year every year, and getting to sort of interact with all of you in sort of more personal way than I get to do in clinic is it's really special for me. So thank you guys for taking the time to spend some time with us. Today I'm going to be talking about two presentations that were given yesterday at the research symposium. And when I do these talks, I try to make them intentionally a little sort of wonky because I want to give you a flavor for sort of what's being shown at those presentations. I will do my best to explain it. The intent is not for you to understand every word on every slide, and I'm also happy to answer questions. Okay. So these are my disclosures, people that I work with, and these are other authors on the first of the two manuscripts. So the first thing I'm going to mention is the nirogacestat and DeFi phase 3 study. I think Dr. Casper, among others, has already sort of covered this pretty well, but the DeFi trial was a randomized, meaning half the patients got nothing and half the patients got nirogacestat, placebo-controlled trial in desmoid tumor patients that had progressing tumors. So tumors that had grown by 20% in the 12 months prior to them going on study. So in contrast to many desmoid tumors that don't grow, these were growing. So we were trying to select for tumors that really needed treatment. And importantly, this was a positive study, and this was big splashy news, Dr. Casper mentioned a couple of years ago at ESMO, when nirogacestat came back with very positive results, and it was ultimately approved by the FDA last year. And what they saw was progression-free survival, meaning how long patients sort of went on before their tumors grew, was 71% better in patients who got nirogacestat versus placebo. The other thing that's often mentioned is response rate. The number of patients whose tumors actually shrunk, which is different from not growing, was 41% in the nirogacestat arm versus 8% in those patients receiving placebo. And I'm going to tell you that because I think patients will often hear those numbers and say, well, only 41% of patients benefit from nirogacestat. And that's not actually how this works. Our definitions when we're talking about response are different from what you might think about when you're thinking about whether your treatment for your desmoid tumor has been a success. So we'll try to touch on that a little bit during this presentation. And the other thing I'll mention, which is really important for the purposes of this presentation, is that this study had a ton of what we call patient-reported outcomes. I don't know if any of the patients that participated in the study are here with us today. In past years, we've been lucky to have some. Thank you for everything that you did. It was a hard study to participate in because there were so many surveys that people had to do frequently. We were collecting all kinds of information about how you felt on treatment. We were asking about pain 6 different ways. It was a real burden, but we learned from that. And I want to show you sort of some of what we're continuing to learn from that. One thing I'm going to mention here is that what you're going to hear today are what we call post hoc analyses. That's a way of saying studies that were done after we had already seen the data from the initial trial. So there are all kinds of rules when you're doing clinical research and interpreting clinical research. The things that are most believable are what we call pre-specified analysis. We've got this drug, we want to see if it works. We design a study, we write out before we treat any patients what we're going to look at, how we're going to look at it. And that ends up being the most believable data that's generated from a trial. That's kind of the stuff that you take to the bank, okay? And there's all kinds of statistical methods and things that go into sort of making sure that that's reasonable. And so for DeFi, the primary outcome, the thing that we were looking at the most, the thing the study was designed to look at, was progression-free survival, okay? How long it took for the tumor to grow, even though many of those tumors didn't grow at all. Secondary endpoints include things like response rate, how many of the tumors shrank. And then there were also multiple additional secondary endpoints that had to do with how patients felt, the patient-reported outcomes, okay? We also did something important in DeFi, which was called pre-specified subgroup analysis, which is a fancy way of saying we're going to look at specific groups of patients within the study and see if they do better or worse on nirogacestat than other patients. For example, we included FAP patients in this study, and we actually looked to see whether FAP patients benefit differently than patients without FAP. It turns out it doesn't seem that they did. They also seemed to benefit from nirogacestat over placebo. We did the same thing for other parameters, whether patients had prior chemotherapy, prior surgery. Those things were included in that primary publication because we had pre-specified them. We had said we are going to look at that before we ever saw the data. Does that make sense? That's different from a post hoc analysis. Post hoc is the study's done, we spent all this money, it was positive, we're very excited. Now let's learn what else we can from these groups of patients. And we start asking questions. The problem is that once you start asking 100 questions about the same set of data, you're going to find associations that may not actually be true in the population just because you've asked enough questions, if that makes sense. And so that's why we always sort of say we qualify post hoc analysis, because post hoc analysis is sort of by definition a little less believable. If you find something there you think it's important, you should probably find a way to go confirm it, if that makes sense. Okay. All right. So the first abstract was the impact of nirogacestat on patient-reported outcomes in adults with desmoid tumors and a best overall response of stable disease. I talked with you before about 41% of patients with nirogacestat and 8% of patients receiving placebo who had a response. So what about those patients who didn't have a response? They had stable disease. Okay. So, and that turns out to be a big chunk of the patients on the nirogacestat study. So that's the box in dark blue there. 50% of patients receiving nirogacestat and 76% of patients receiving placebo in the study had what we would classify as stable disease. So a big chunk of the patients, most of the patients, you might say. Turns out their characteristics pretty much well match the population of patients on the study, more females than males, a younger population, 34 years of age, and similar between the two groups. Some patients had other treatments, some hadn't. So patients were asked to look at to complete a bunch of different patient-reported outcomes instruments, as I told you. There's a brief pain index short form, which is just a 1 to 10. Please rank your pain in the prior 24 hours. There's this specific instrument that DTRF was instrumental in developing called the Goddess DTSS, which looks at desmoid-related symptoms, not just pain, but mobility and other things as well. And then there's a survey that was developed by the EORTC, which is the European Oncology Organization, which looks at quality of life and pain. So patients filled out all of these instruments, and we're going to be looking at how those patients with stable disease did getting nirogacestat versus placebo. Okay, so here's a few of them. So this is on the far right, you see the improvements in pain. So what you see is on the gray line on the top is patients getting placebo. And you can see that that line, it doesn't go up or down. It kind of bounces around a little bit, right? So it sort of stays the same. Patients on placebo, they didn't seem to have a definitive improvement in their pain. Now look at the light blue line on the bottom. That's patients getting nirogacestat. And you can see going from the baseline, which is the dot all the way on the right, to the next dot, pain gets better, and then it stays better all the way through. Okay, and this is what we saw on the nirogacestat study for all of the patients on the study, but now we're looking at just the patients who had stable disease, who were not responders with nirogacestat. They still had improvements in their pain. That was also true for this Goddess Total Symptom Scale, which looks at more dimensions than just pain. It asks about quality of pain and impact of the pain. And then the physical functioning domain of the Goddess, which looks at sort of what people can do and what their limitations are in terms of function from their desmoid. All of those things get better quickly, and they kind of stay better on the trial. The reason there's a rectangle around one of those dots is that's when the study had said we were going to look at patient-reported outcomes. That was after 10 cycles of treatment. Okay. These are the EORTC PROs, so similar to what you saw with the other ones. Physical functioning, role functioning, being able to do the things you want to do in your daily life, and overall quality of life all seem to be better at cycle 10. You can see overall quality of life is not convincingly better right at the beginning and staying better. But at that time they chose to look at it, cycle 10, it does look better, but I would say that's not as clean as the others, okay? All right, so the conclusion is that in this randomized DeFi study, we knew already that in the total populations, patients getting placebo, patients getting the drug, people felt better, their pain was better, physical function was better. But this demonstrates even in those patients that didn't have quite the same level of response, you still see a symptomatic improvement in those patients who got nirogacestat versus placebo. Okay. All right, I'm going to go right into the next one, and then we'll talk about questions if anybody has them. All right. So then the next thing we're going to look at is patients who had reductions in pain and sort of how that translated to improvements in their physical function. What was better because pain was better? What could they do more of that they couldn't do before? Okay. So we had about 20 patients on that larger study of 142 patients who had what we would call clinically significant pain when they went on the study, had been good about filling out all of their PROs such that we had the same information at cycle 10. and then had a clinically significant improvement in their pain. Because, we don't, just because their score went from 10 to 9, we don't know if that actually means anything or not. And so there's this convention that an improvement of 2 points on that 1 to 10 pain score is considered clinically significant, something that it would actually mean that a patient would say, hey, my pain is better. So in those 20 patients that had clinically significant improvements in their pain, what's better? What can they do better? What elements of quality of life are improved because their pain is better or in association with their pain being better? So the first thing we looked at was, does having an improvement in pain sort of correlate with an improvement in physical functioning, role functioning, and so forth? And so this gets a little wonky, okay? But there are 4 instruments that we looked at. There's the BPI short form pain interference index, which asks some questions about how pain is interfering with your daily life. And I'm going to show you that, which was strongly correlated. So if pain was better, this tended to be better also. The Goddess DTIS and the EORTC role functioning survey was a little bit correlated. There did seem to be a moderate correlation that they went in the same direction. And that final survey, the physical functioning, was weakly correlated. And I'm not going to talk about that one again. Okay, so then we go back and actually look at the questions that are in the survey, okay? So for the BPI short form pain interference index, it's a 1 to 10 scale, and we're asking people how they are doing with these specific things. So on a 1 to 10 scale, patients who had clinically significant improvements in pain reported that their sleep was 4 points better. I mean, that sounds like a big jump. What does that exactly mean? It's hard to say. These are subjective questions, but you see that trend, right? Other items like enjoyment of life, being able to do normal work, their mood, their general activity, those were all improved by about 3 points. And so you see this trend towards improvement in these domains. The next is the Goddess physical functioning. This is a different set of questions, and it's a different scale. It's not 1 to 10, it's 1 to 5. And so the numbers here are lower. It's not 4 and 3s anymore, so it's a 1.69, but that's because it's out of 5. And you can see that patients' ability to move near the tumor was improved by about 1.5 for 2 categories, and the rest were improved about 1 category on that 5-point scale, including vigorous activities, moderate activities, and then being able to accomplish what you want to do in a day, for example. Okay, so that's kind of a flavor for what we were looking at, is just sort of trying to get a sense of not just, are you feeling better, but how are you feeling better if in fact your pain is improved, if you have a desmoid tumor. Questions on any of that stuff? Yep.
Thank you for your work, Doctor. I guess it was brought up earlier. I understand Neuro's the only sort of FDA-approved drug for desmoid tumors, but I think sorafenib was brought up earlier. It doesn't sound like we're going to get a study sort of comparing them head to head. So I guess in your mind, I'm just trying to understand the advantages.
Yeah.
Given I know the response rate was a secondary objective, but in Dr. Thierry's presentation, I think the response rates were fairly similar. I think 30, 40% sorafenib, 40% for Neuro. Are there advantages obviously beyond that?
Great question. The answer again gets a little wonky, right? So what you just did there is what's called a cross-trial comparison. You're looking at 2 different studies that don't actually compare to each other, but the problem is it wasn't the same patients on both studies, right? So in the sorafenib study, the patients who went on it were patients who someone said no to surgery, they felt they weren't a candidate for surgery, or they just had some tumor symptoms related to their tumor. And so the placebo arm, the patients who got nothing on that study, had a response rate of 20%. On the nirogacestat study, all of those patients had to have growing tumors when they went on the study. So their placebo rate, same treatment, nothing, right, was 8%. So then being able to compare the response rates on the other side becomes dicey also, because the natural history of what would have happened to those patients anyway is probably different. Does that make sense? And so I think we have to be careful about standing at a podium and saying one is better than the other. I don't think that it is. I think what I would say is that, a drug approval is a wonderful thing, right? It means that they've met a standard of evidence that the FDA requires to say, yes, you can say that this drug works in this disease and you can market it as such, right? Sorafenib is different because it was already on the market for other cancers. So for nirogacestat, if it hadn't been FDA approved, you would not have been able to get it, right? So that was a big deal. Sorafenib is available. So the indication, I think, is important. It is meaningful, but I don't think it's a badge of supremacy. It's just sort of a an acknowledgement that they've met this burden of evidence specifically for desmoid tumor patients. Most of us think the sorafenib study was also very high quality, but there's reasons why a company may or may not pursue doing a full approval. I don't know if that fully answers your question. Was there another part to it?
Difficult to kind of cross compare, I think, is the main thing.
Yeah. And I think that, nirogacestat has been really helpful. It is a well-tolerated drug. Quality of life is better on that drug. We don't have that level of data for sorafenib. We don't have these surveys for it. Subjectively, and as Dr. Casper mentioned, when it gets approved in Europe, it's likely going to be something that people use first. I think that's been our experience here as well, in large part because for many patients, it's quite tolerable in a way that sorafenib can sometimes be challenging. But I try to be careful about making statements about supremacy, if that makes sense.